Deb Knight, I'm here to do your exam today.
I'm Mike, how are you?
Good, I understand you have an ankle problem.
It hurts.
Oh, boy. Okay, well, we took your history, so we're going to move on with your physical exam.
Okay.
And I'm going to wash my hands, and just on general inspection, noticing any obvious abnormalities, any obvious pain or splinting, even a little diaphoresis if he's in shock, and that's about all I can think of in the general survey, his general posture. We're going to look also at the ankle. I'm going to have you scoot back a little bit so I don't have to bend over so far. And we're going to have it be this ankle? Let's have it be this ankle.
It was this ankle,
Okay,
actually.
good. Now slide forward a little
Rolled it
bit.
playing basketball.
There, perfect. Okay, good. So what we're going to do is take a look at this ankle, and we'll put the other one up for comparison, but we're going to look for any obvious, the alignment and symmetry of the ankle and of the foot. We will get you up and look at the inner longitudinal arch in a little bit here, but we just kind of look at it here, but we're going to look at it above too. And we're going to also look at your walking. In fact, why don't you hop off the table? And first stand in front of me. You're good. And could you stand stand up straight and just, I'm going to look at the obvious alignment in a standing position. I'm going to look at the inner longitudinal arch here with his feet. Just bear your weight normally. See if it is, comparable, or if we've got a flat inner longitudinal arch or very high arch. I'm going to show walk forward toward me the best you can. Good. You notice any obvious limp. All right, good. Come on back. And then also, could you stand for me? And I want to make sure he's not pronating or supinating. Could you pronate for me? Pronate, supinate, good, or supinating. We want to make sure that he's in neutral. Okay, hop up on the table. All right, now we're just going to push on this affected side, okay? And you can, there you go. That's comfortable. All right, I'm going to go ahead and do a quick little drawing for our viewers, okay? Anterior tib fib, anterior talofib, lateral talocalcaneal, calcaneal fib, posterior talofib, posterior tib fib. We'll go our deltoid over here.
Looks like his son.
Okay? Here's the head of the fib, just in case you want to know. All right, so we're going to go through, and I'm going to first do some pushing. This patient came in with an ankle sprain, so I want to make sure the tib and the fib are okay. So you let me know if you have any soreness. I'm going to start way up here, and I'm going to push right on the fibula. And is there any tenderness there or anything? No? Good. And I'm going to come all the way down to the lateral malleolus and push on it, looking for tenderness. Then I'm going to do the tibia, the flat area of the tibia, looking for any tenderness, and the medial malleolus also, looking for any tenderness. Okay? Then we're going to go ahead and do the ligaments. I'll start with the lateral side here. And with one finger, I'm going to push in these spots, and what I'm looking to see is if you have any pain, okay? So this is the anterior tib fib ligament. It goes straight through from the tibia to the fibula, looking for any discomfort. Then here's the anterior talofibular ligament. Oh, that one hurts you, huh?
Yeah.
Lateral talocalcaneal. And calcaneal fib right at about 6 o'clock. The posterior talofibular and the posterior tib fib. And again, one finger, and we're looking for tenderness in each one of those ligaments. And then on the deltoid ligament, on the medial side, we're going to palpate right across on the deltoid. And again, looking for any tenderness. All right? And then the base of the fifth metatarsal down here, sometimes when we have the inversion, we can take a little piece of bone off, or we can fracture that fifth metatarsal. So we're looking for any tenderness on the head. You can even palpate the entire fifth metatarsal, but head of the fifth metatarsal at least. And then we're also going to palpate the Achilles tendon, looking for any tenderness. Start low at its insertion on the calcaneus and come up. Okay? Now we're going to go ahead and I'm going to have you put up your other leg. And can you do some movements for me? Can you point your toes as far as you can go? And we're going to compare bilaterally. And now bring them all the way up, toes to your nose, dorsiflexion as far as you can. Good. And now just the soles of your feet turn inward. Good. Perfect. And that's inversion. And now just the soles of your feet turn outward. And that's eversion. Just looking to see if they're symmetric. And then I'm going to test your strength. And on this one, we'll do the good to the affected, okay? So pull up against me as hard as you can. Resisted dorsiflexion. And now I'm going to get myself stable here. Resisted plantar flexion. I'll do it on this side. Dorsiflexion, good. And plantar flexion, good. Then I'm going to do inversion and eversion on the unaffected. So to the patient, I say kind of push your foot inward against my hand, okay? Good. And now this way, this eversion is you're going to go outward like this. So push yourself outward against my hand. Perfect. Same thing here, inward against my hand, and I'm kind of counter-stabilizing with my other hand, and then outward against my hand. And you can allow him to go through some of the range, that's okay. And if he's not sure and he's abducting his leg, go back and kind of show him what inversion and eversion are. Okay, we don't want him to roll the leg, we want it to stay nice and solid. Okay, so that's our strength, and then we're going to do our special tests. So our first special test is the anterior draw test, or anterior draw test. This one particularly involves the anterior talofibular ligament and can involve any of the lateral ligaments, but particularly anterior talofib. We're going to check the good side first, okay? So just relax. You can, lay back. Perfect. And we're going to go ahead and just check, and I'm going to cup underneath the heel. I'm going to stabilize above the malleoli, and I'm going to draw his foot forward toward me. We're not doing much plantar and dorsiflexion. We're just drawing it forward, trying to pull the cup of my hand up toward my chin. And then we're going to slide over here on this side, same thing, relax. And I put him up about, not quite up to 90, but pretty darn close. And I'm going to stabilize. And on this one, oops, relax a little bit. There you go. And you can almost see right here, you don't have much looseness at all, but you can see where it kind of opens up and gaps there. You can see I'm pulling on that ligament, but it seems to be very nice and stable.
Oh, thanks.
Okay? So that's our anterior draw test. Then our talar tilt test, we got to go to the subtalar joint. Now we got to put our upper hand down a little bit, right over the medial and lateral malleolus. We're going to try to cup this heel, and we're going to try to grab a hold of the talus and calcaneus and actually tip the talus and pull it back and forth inside the mortise, okay? So my upper hand is down a little lower. My lower hand grabs a hold of the heel, and my movement is going to be this, or even a tip, tip, tip. I kind of do both. So I go sideways, or even tipping. And I want to feel a bang, bang, bang movement if it's affected, if we have a positive talar tilt. Then I go to the affected side, and a tip, and a clunk, 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 or extra movement there would be positive on that. Okay? We also have to do our tests for fracture. Those were our tests for ligament stability. Now we got a test for fractures. And we would have already kind of had an idea if he had a tibial or fibular fracture based on the history and also even palpating around, but we'll do some special tests. The tib-fib squeeze test is pushing above let's say he had point tenderness on his fibula down here in the distal 1/3. I'm going to push above it. I'm going to watch him and say, does that hurt you? And that was a positive just now, that ooh. And where does it hurt? And he would point down where the fracture site is. Okay? We're not moving the joint around at all. We're just pushing on the bones. If it was a tibial, certainly above it would cause tibial pain. We're going to do the heel tap test. We're going to put him in a comfortable position at about 90 degrees best we can, and all I'm going to do is tap ever so gently on the bottom of his heel. And all I'm doing is sending that vibratory stimulus up through the calcaneus, talus, tib, fib, okay? I tap gently at first. Does that hurt you? Good, I'm going to tap a little stronger. And if he goes, ooh, and says, yeah, that hurts, again, I find out where does it hurt. If it's a distal fibular, distal tibial, he'll be pointing to that spot. Sometimes in a talar fracture, he'll say, yes, that hurts a lot deep inside because you're vibrating the bones. Certainly if it's a calcaneal fracture, you're banging on it, so it hurts. What else? Thompson. We're going to ask you to, well, actually, we can stay in this position, actually, or we can, I'm going to have you flip over on your belly, if you would.
Yeah, that's fine.
Just in case let's say we got a big ankle, and it looks like they got an ankle sprain. We want to double check and make sure that Achilles tendon is in place. All we simply have to do is squeeze the calf, and look what happens. Plantar flexion. You can even compare it bilaterally if you like, but a positive test would be nothing happens there, or it's very minimal compared to the other side. Okay, so Achilles tendon rupture. And that's it. Oh, which one?
Caffeine,
What's that?
positive caffeine.
Oh, okay. I didn't know that was on there, but let's do it. Flip back over again. Let's say that he comes in with calf pain, and you can't figure out if he strained his Achilles or his calf, or maybe he has a DVT. One of the tests, but it's actually becoming less and less reliable, but you will see it out there and hear about it, is the Homan's test. And what it is we're going to squeeze the calf deeply where the discomfort is, deep inside, and then we're going to passively dorsiflex them. And between our pressure on the DVT that's happening in there and our passive dorsiflexion, a positive would be pain. The problem with this test is you could have an Achilles tendon strain and have the exact same, and you could have a DVT and not have a positive Homan. So it's beginning to move away from its reliability, and your gut feeling, if you think they have a DVT, go get them an ultrasound. Is that it?